All right. So this is a presentation that I made for the critical care service line with Erin Scott, who's like the chair. She's an intern doing IR at MUSC. She asked me to do this, so I did this a couple months ago for SIRFS. So basically it talks about, we're going to talk about some of the advantages of interventional radiology in ICU care and what we can offer, what things we can do as well or more safely as far as bedside procedures and some things that should be better done in IR. The benefit of IR, VIR, is that minimally invasive image-guided therapy is often better for critically ill patients. A lot of these patients can't get to surgery or they're critically ill, they might be unstable. At the bedside, a lot of procedures can be done. Any image guidance you can use for these procedures that are kind of mostly percutaneous through the skin without opening people up can make them safer because you can basically tell where you are. Other procedures that you can't do at the bedside can be done in the VIR suites with different varying levels of analgesia or sedation plus analgesia, depending on the physical status and ability of that patient to cooperate. If the patient can't cooperate, they can't do a procedure unless they're under anesthesia. A lot of these patients that are in the ICUs are already intubated, so they might come with their nurses. If they're basically been intubated for a while, they can kind of just titrate their meds with their ICU nurse rather than requiring anesthesia for the case. So sometimes the question is, should this procedure be done at the bedside or should it be done in the suite? The benefits of doing it in the suite, you have intraprocedural monitoring that is specific to IR, and we have our own moderate sedation nurses that are there helping to monitor. You also have monitoring in the ICUs too. Like every patient in the ICU is going to have some level of monitoring unless they're, trying to be transferred to the floor and just kind of waiting on a bed sort of status. But in general, everyone's going to have, telemetry that EKG leads. They're checking their respiratory rate. They might have invasive arterial pressure monitoring with like a radial art line or femoral line. And then we'll talk about procedures that are often performed on critically ill patients, and then talk about like IR residency ICU rotations. This is timely because I am on the surgical trauma burn ICU rotation right now. So I'm doing a lot of this stuff. And then critical care IR is kind of a subject, kind of niche thing that doesn't exist that much. There's actually one guy that actually does practice critical care IR that I know of. So if you can get a patient to the VIR suite, it's generally best, given that you have the appropriate staff and monitoring equipment to do these image-guided procedures. Like I said, you have a lot of the same equipment in the ICU, but for example, MUSC's ICU, those beds are not like radiolucent beds that you can take a C-arm and fluoro through. So a lot of these things, you can do x-rays on these patients by sliding the cassette into the bed. Like it has a slot for it that it fits in there. You can do like an x-ray, but you can't fit an actual C-arm like under the bed and above the bed and fluoro through it. The bed is radio-opaque. So that's one limitation for fluoroscopic guided procedures. Again, on bedside, you have to either get them into a bed that you can fluoro through, fluoro-compatible bed, or do things with ultrasound. Higher quality imaging that you have in the fluoro suite, it's going to be, the C-arm versus actual dual plane fluoro image guided stuff with much higher quality in the fluoro suite. So you're going to see more of what you're doing compared to a C-arm. And then you have multiple modalities available here. This is an example of a hybrid suite that I have in this picture where they have a fluoroscopic unit, but also have a CT scanner. So you can do some procedures that might start in CT, like you're going to do a G-tube into an excluded stomach that you couldn't insufflate with an NG tube, for example, or very difficult nephrostomy tube placements can sometimes be started in CT and then transferred to the fluoro room. In this room, you basically just slide them to the scanner, slide them back out, and you can do fluoro. So one advantage is going to be technical success. So for example, like a cholecystostomy tube, patients in the ICU often will get acalculous cholecystitis, or they'll get, fever of unknown origin. You get to look at the gallbladder from right upper quadrant ultrasound. You find out it's a little bit dilated, walls a little thick. It's debatable whether they have cholecystitis, but we've kind of ruled everything else out, and they have a white count and they have fevers. Let's put a gallbladder tube into this patient. They're not stable enough for surgery, so do a cholecystostomy. So you can do these in the you can do them in the ICU or in IR with ultrasound only. Sometimes they are done that way, and you can, with ultrasound in an appropriate window, you can actually see everything you're doing. You can see your wire basically curling up inside the gallbladder. You can see when you're putting your dilator in there exactly how far you need to go, and see your pigtail curl up. You don't always see that though as well as you can see with fluoro. So traditional ways to do it with ultrasound and then with fluoro guidance after. So that's kind of the safest and best way to do that. In order to do that, you need to be in IR for a fluoro room. If you do it in the ICU, you could do it with the C-arm to see what you're doing after you do the tube, but you're more or less just going to use ultrasound imaging to do that. This is kind of an example of why, if this patient can come to IR, because there's a reason that IR is IR. It has all the best equipment to do IR guided procedures all in the same place, and you have the staff and everyone that's familiar with doing this versus coming to the floor to doing some of these procedures. But a lot of times having an interventional radiologist come to the bedside to do a procedure like this would kind of be, the next best thing to actually taking them to IR. But if they can go to IR, I think my opinion is that you should get them up there so you can do it with the proper equipment. So then cholecystostomy, use ultrasound to guide through the liver to the gallbladder. You want to go through the liver ideally with a cholecystostomy tube. There's not really great evidence for going liver versus just going through the peritoneum, but the idea is that the drain is more secure if it goes through the liver as like an anchor. If you're in the peritoneum, you're kind of hanging freely and then you form your pigtail, but then the rest of the drain isn't really secured in there. If you go through the liver parenchyma, you have more stability. So things that you can do if you have fluoroscopy and you're worried about an injury, you can inject contrast to see if you have like a vascular injury. You can also get vascular access quickly and do angiography to see if there's a problem and something needs embolized. Those are all things you can't really find out if you're just doing with ultrasound. So if you get into a situation where your tube is very bloody, sometimes you'll put the tube in that will obturate that bleeding. Sometimes it won't. In those cases where it won't, you might want to do angio and embolize. You could quickly do that if you're on IR. You can kind of troubleshoot problems that you can't troubleshoot on the floor. And so it's good if you at least have ultrasound, because not a cholecystostomy tube would never be done this way, but things like lines, for example, can be done in IR with a ultrasound, fluoroscopy, and seeing where your needle or wire and needle is, and make sure you're in the right place before you put your catheter in. To done in the ICU with just an ultrasound, to being done just by landmarks where people are just kind of sticking and using landmarks for safety, and more or less you're hoping for the best in some of these things where you really can't tell what you're doing until you get that x-ray after to confirm placement. So you can tell it's just safer and it's actually quicker to do things with image guidance too. So intraprocedural monitoring. These patients that come to IR are going to have all the basic intraprocedural monitoring. That's kind of the same monitor you might see in an ICU. If they come to the ICU, they're going to come with an ICU nurse. That's usually a requirement, like at least MUSC, probably other places too. Sometimes with a respiratory therapist, depending on how labile their vent settings are. And then some, if they are really unstable, they'll come with anesthesia too. Will be booked as an anesthesia case, even though from the ICU, anesthesiologist will still take care of them and manage their ventilator and their physiology during the case. Otherwise, it's going to be the moderate sedation nurses plus the SICU nurse or MSICU nurse will kind of sit back in the control room and watch and help out. So this is a list of procedures that we perform on critically ill patients, and we'll go through a lot of these in a little bit of depth. I'll kind of try to stay pretty superficial so we don't get bogged down. But abscess collections, aspirations where you're just sampling things. I've done both of those in the ICU so far this month. Percutaneous nephrostomy, that's going to be something you're almost always going to bring them to IR for. Percutaneous biliary work, same thing, except for cholecystostomies, which can be done sometimes in the ICU. Bronchial artery embolization, that requires an IR. Angio suite, arteriovenous thrombolysis have to go to IR. Pulmonary embolism, there's different treatments for that. Almost everything required would require going to IR. You can place IVT filters at the bedside. Sometimes trauma does that with certain catheters. We basically never do that. We do all those under fluoroscopy. GI bleeding, TIPS procedures, BRTO, PRTO, foreign body removal with fluoroscopy. Central venous catheters often done in the ICU every day, and then trauma procedures. So this is an example of a retroperitoneal collection. Sometimes with CT, you can sort of tell what something is. If it has enhancing wall, very hypotenuating uniform on the inside, you might be able to suspect that it's an abscess, given the patient has a white count and a fever and everything else that goes along with an infection. It would make sense that it is, but you can't 100% know until you sample it. So first, when you start with this procedure, you get that needle in there, you get pus back, and to put a drain in there. If you put a needle in there and basically what comes out, it just seems like hematoma or kind of liquefying blood clot, it might not be a good idea to place a drain because you're then maybe seeding a hematoma that's not infected, making it an abscess. But this is a CT guided procedure. You could do that. This is probably an okay place to do this ultrasound too. You got to worry about bowel when you use ultrasound because bowel has gas in it and you will kind of gas everything out behind it, and you don't want to place one of these tubes through the bowel. It can happen. So basically perienteric drains or like enteric abscesses should generally be drained with CT because of that risk. In certain instances, ultrasound is appropriate, but for the most part, you want to use CT. So the reason to drain these, the alternative to draining abscesses percutaneously, or doing aspiration, drainage, or percutaneous washout procedures, is basically a surgical debridement of the abscess, like open drainage. So there's a lot of mortality associated with that. So if you can get someone to do this percutaneously with ultrasound or with CT, it's going to be safer. You get source control. You can stop antibiotics after you get this fully drained. Well, something is still draining, it still has output. There's some kind of debate about whether or not they need to still be on antibiotics, because do you really have source control until it's completely drained? But this can give you source control where you don't need to just treat with antibiotics like indefinitely. Abscesses can be like, you can have intraperitoneal pulmonary abscesses. Those are typically treated with medical treatment first. 85% will resolve with medical treatment depending on the size of it. You can have pleural collections. Those are usually called an empyema. You can have intra-abdominal abscesses like the one that we saw before. This is retroperitoneal. You can have abscesses in the skin, muscles, anywhere basically in the body that can be drained. And sometimes you don't really know what it is until you aspirate. So they'll ask us to aspirate something. Sometimes it's small enough that it can be treated with antibiotics, but it might be someone that has multiple infections, or they want to narrow their antibiotics, and so they want to sample it so they can treat specific things based on the sensitivities, and we'll do that too. We'll aspirate things. That can easily be done at the bedside with ultrasound. Some people in the ICU are comfortable with that, but some aren't. So sometimes we'll come to the ICU to do that. And actually on the ICU rotation, I've done that for them with ultrasound. I've actually sampled collections for them, sent off cultures. So not a lot of complications if you do this and you can see everything that you're doing the whole time. When you do a non-contrast CT, you kind of have to know where the blood vessels are on a previous CT to know where to be safe. Otherwise, you kind of want to stay very midline or go pretty lateral to avoid those inferior epigastric vessels. Something to think about. Percutaneous nephrostomy. You guys probably heard about this. This is a procedure that you would do for someone that's obstructed that gets infected, someone that's obstructed that's going to compromise their kidney function. So you're taking that pressure off of the kidney. The obstructed kidneys often get infected, so sometimes you have both things. You have an AKI because of obstruction, but you also have an infection. So that'd be like urosepsis. And also another thing would be like if you have a staghorn calculus, they'll want to do percutaneous like lithotripsy, and they will basically upsize that to like 20 to 30 French, which is a very big catheter, not the one that we put in. We put in a pigtail catheter right next to the stone. They go straight to the operating room from IR, and then through our catheter, they put a wire in, and they upsize it and do their procedures through that large catheter. So you can have major bleeding up to 1 to 4% of these percutaneous nephrostomy tubes. You try to stay in a plane called avascular plane of Brodel, which you use kind of landmark guidance on the outside of the patient. Try to stay 30 degrees off sagittal. It's supposed to avoid the anterior posterior divisions of the renal artery. In practice, you use ultrasound and you kind of find the best approach and try to stay close to that. But I don't know if the avascular plane of Brodel is exactly the same in every patient. You kind of use image guidance in real time to figure it out. Procedure basically involves getting a needle in there, seeing that you have urine come back through the kidney after you're in the collecting system, putting a wire down, then you salvage technique and you get a tube in there. Sometimes you go all the way down to the bladder if you're doing a nephroureteral tube. So this could potentially, I've never seen this done or heard of this. Actually, I've heard of this, but never seen this done at the bedside. If somebody had if they're very unstable and they had urosepsis because they had like pyelonephrosis, you could put a needle into that with ultrasound guidance and then place a pigtail catheter into that collecting system without image guidance. But the image guidance part is where after you get your needle in, you want to see your wire track down into your ureter to confirm for safety that you're in the right place, and also to give you kind of a distal stability to track your catheter in there. But if you needed to, you could put a wire down and put like a compi catheter or something that decompresses the urinary system emergently. But I haven't seen that done much, but it's a thought. Usually they say they're not stable enough to transfer them to IR for the nephrostomy tube. Like it's not a good idea. Like it's in that case, the procedure is usually not done. But I could see some instances where you could do bedside drainage of pyelonephrosis with ultrasound, but it's not a common thing. Percutaneous biliary drainage, similar to the kidneys. When the biliary system gets obstructed, it can become infected. You can have biliary cholangitis. You can also have, cholecystitis is also usually obstructed at the cystic duct. So both those can be drained. You can put a biliary catheter either through the right or left hepatic ducts. You go a little bit peripheral, you pass your wire down, you get into the duodenum like this picture on the top right is, and then you place your drainage catheter. Depending on what your goals are, why you're doing this procedure, will kind of change whether or not you leave a internal external biliary drain, just an external biliary drain, you put a stent through there, etc. So this procedure, you usually want to start ERCP first. So in general, as a medical student and someone has like a biliary obstruction or cholangitis, all these things, or choledocholithiasis, the first step is going to be ERCP. The reason you're doing that, you're not, when you do percutaneously, you're putting a hole like in the liver to get through the biliary system. You're doing percutaneously, it's better than open surgery to drain a problem like this, but you are making a connection from the outside to the inside. When you do ERCP, you're going through all natural tubing inside the body. You know, you're going through the mouth, to the esophagus, into the stomach, into the duodenum, out the sphincter of Oddi, and up into the biliary tree. And so you are cleaning things out from the inside. You can pull your stones, even sweep them out into the duodenum and not have any issues. When you go the other way, it's also safe, but it's not preferred to instrument that from the outside. So if you can do it from the inside, it's usually done first. Sometimes it's not possible though. If they have like a hepatico-jejunostomy that can't be accessed from the stomach because it's too distal to pass an endoscope up there, that'd be a good time to do biliary drainage. Sometimes you have a failed ERCP, that'd be another time. The hepatico-J, like I said, if you try to decompress choledocholithiasis after ERCP, that's the time. Malignant obstructions that can't be passed from below too, and then traumatic bile duct injury, like after a transected like biliary duct during a cholecystectomy, for example, that'd be a good time to put an external biliary drain in to decompress that in the meantime to let that heal. Sometimes someone will come in and they have a traumatic biloma and they also have that biliary leak that's leaking into the biloma. So in that case, usually because bile is very irritating to the peritoneum and cause peritonitis, you will put a drainage catheter, like an external one, into the biloma that's in the peritoneum, and you'll also do external biliary drainage. External biliary drainage will stop that biloma from filling. In the external drain that you place, the second drain will actually drain the biloma actively. So once that one stops putting out, you can take that biloma drain out of there first, knowing that you've diverted your biliary drainage with your internal external biliary drain. And then once you internalize that drain, then you can take out the external component or take it out all together if you no longer need it. Internal external biliary drainage catheter has a drainage way from the outside and also drains on the inside. You can cap the outside and see if your internal drainage is working, and then you can take your external part of biliary drain out. Bronchial artery embolization indications for this are massive hemoptysis. This can happen to patients in the ICU, usually more like a medical ICU than a surgical ICU. It's like a problem that develops a lot of patients with cystic fibrosis, for example. Life-threatening hemoptysis is the indication that's a strictly defined thing. It's actually 300 milliliters in 24 hours or 100 milliliters over 3 days, each day having at least 100 milliliters. So like 300 milliliters total over that long. We used to have 100 milliliters in each of those I guess it says 36 hours. I think it's actually 3 days. So maybe it should be 72 hours. And then instability caused by the hemoptysis is another thing. I'll check on that and update this slide. Usually that's from the bronchial artery, rarely from the pulmonary arteries, and 5% of the time from other systemic arteries that feed the pulmonary vasculature. So a reason to do this instead of doing like a VATS and ligating some, or like a thoracotomy and ligating some of these arteries that you have preserved pulmonary function, you can embolize these bronchial arteries and they have duals of blood supply to the lungs and still have that lung be perfused, but deal with your problem. So cystic fibrosis, TB, interstitial lung disease, fungal infections, bronchial aneurysms. Sometimes this can be iatrogenic after a Swan-Ganz catheter that gets put too far distal. So as a radiologist, part of your job is to tell them that the bronchial artery Swan-Ganz catheter is an appropriate place. So we basically cut the lungs into thirds, medial, middle, and lateral, and then you don't want it to be beyond that half of that 2/3 section. You kind of want it to be in the medial third. Out beyond there, the pulmonary arteries get small, and you can cause pseudoaneurysms, and that can cause massive bleeding. So pseudoaneurysms aren't common aneurysms of any of those arteries. Only in the settings of those catheterization will you really see those. Most of the time, the ones that I've seen of this have been for cystic fibrosis almost uniformly. So in this case, you get access into the common femoral artery. You could do radial artery too, and then you catheterize those bronchial arteries. Usually you have 2 left and 1 right, but there's a lot of variation in those. You usually use PVA, very cheap embolic material, polyvinyl alcohol. It has a range of sizes versus like embospheres, which are very uniform. This one is just kind of stuff that's cut up, and the specs is like 250 to 500. You can have post-embolization syndrome anytime you embolize any solid organs. That's kind of that nausea, white count, and fever. It can happen usually 3 to 5 days after any of these embolization procedures. Spinal ischemia is like the most feared complication in bronchial artery embolization. That's where you need to watch out for your artery of Adamkiewicz. It's like a hairpin-shaped artery. Let's see if I have that picture up here. Considered an artery of Adamkiewicz. Anytime you see like a hairpin-shaped artery, if it's anterior medullary or anterior radiculomedullary artery, we call it the artery of Adamkiewicz. I think it's actually supposed to arise from like much lower than this one, but in that case, used to be thought like anytime you see that, just don't do this because you might have anterior spinal cord ischemia and paralysis. But now we have good microcatheters, kind of newer equipment. You can get well beyond where that artery comes off, where it bifurcates into giving off the anterior spinal artery, and you can avoid embolizing altogether just by getting more distal and still complete your procedure. There's also a provocative test you can actually inject an anesthetic into there, like into where you're going to embolize, and see if the patient develops neurologic symptoms temporarily based on injecting your temporary anesthetic like a lidocaine. And if they have symptoms like paralysis, then you don't do the procedure. If they don't, then you can go forward with it. But usually you're just gonna get distal enough, and I've never actually seen anybody do that test. Pulmonary embolism, kind of a pretty cool thing that we're treating a lot now. We're on the PERT team at Maine and at ART at Maine when they need a procedure. We're the ones that do that. At ART, usually it's cardiology. But pulmonary embolism, these are going to be your submassive, massive PEs. The criteria for those is is not based on like image findings, other than you need to find a PE. And if you're going to call a massive or submassive PE, it should be a large central PE, but it's clinical criteria. So we never say that in a radiology report that this is a massive pulmonary embolism or this is submassive pulmonary embolism. You just might say large central pulmonary embolism because those are clinical criterion. So you have to have right ventricular dysfunction to call it submassive. You can find that either on a TTE, where you're going to have like intraventricular bowing, the right ventricle might be dilated, compared to like RV-LV ratio might be higher, right atrium might be dilated, you might have reflex into the hepatic veins, for example. And then CT, you're going to see the same findings that you see on TTE. TT is going to be a little more sensitive than a CT, but a CT RV-LV ratio is pretty good test too. And then BMP, which evaluates I think right atrial or right heart stretch, will be elevated too. It's another indicator of right ventricular dysfunction. And then myocardial necrosis, as indicated by troponin in this correct clinical setting of having a PE. So if you have either one, you can call it submassive. Massive is defined by like a few criteria. You have to have hypotension, like profound hypotension, with your systolic is less than 90 for 15 minutes. Blood pressure change of 40 from baseline, which you usually don't know because if someone comes in from the outside, they have a big saddle embolus and their blood pressure is low. We can know it's low, but you don't really know what their baseline is unless there's someone that follows religiously with their primary care provider and has lots of blood pressure monitoring. Pulselessness, obviously, profound bradycardia is one thing, and then in these settings, usually you're going to go TPA first. At certain institutions, they actually will take these patients straight to thrombectomy, but you have to be very sophisticated and quick to do this. So these patients are going to die, and they die fast. So that's why you would give systemic thrombolysis too. Some submassive will get that systemic thrombolysis as well. We use this SPSI score. We use that in IR. It's based on these things you get points for. It's either basically 0 or 1 or greater than 1. If you have at least 1 point, you have a 30-day mortality of about 9%. And then we have risk stratification from ESC 2019, European Society of Cardiology. And we use all these risk stratification scores, not to get too nitty gritty about it, and we kind of decide based on like which of these patients need to get a thrombectomy, who needs TPA, who needs just heparin. So the downside of the systemic TPA, though, why not just give it to everybody? Like 9% will develop major bleeding, and then 2% will have hemorrhagic stroke. So that's not insignificant. When you're talking about mortality with these submassives often being as high as 10%, you're still, mortality is 10%, major bleeding is 9%, you'd want to give it in that case because your mortality is as high as your risk of major bleeding. But in other cases where it's massive and your mortality risk can be much, much higher than that, then it's clearer to give it. But it does leave a lot of room for improvement when you're giving systemic TPA. So that's some of the stuff that we've developed over time. The indications, like I said, of these are in flux. It's something that we're really working on at MUSC. Even massive, after you give TPA, basically they're still hypotensive, they're still bradycardic, they're still having any of the symptoms of massive PE. That's when someone needs to get, some next procedure. You can give it prior to TPA, like I said, with local expertise in thrombectomy. So you'll be able to do this quick because giving TPA is going to be the quickest, fastest way to lyse that giant clot that's killing the patient. And if they go to an endovascular suite, then you'll be able to treat this problem quickly, or you're gonna have the same outcome that you had if you didn't give TPA. Some cases TPA is contraindicated. A lot of these patients will be post-surgical. They might have like brain mets from melanoma, which can be hemorrhagic, or any kind of brain mets really. and then submassive with a contraindication to anticoagulation. If someone has a submassive PE, they're having right heart strain from it, it's probably not going to get better. It might get worse, and it might get larger because you can't give the patient anticoagulation. So sometimes you might go straight to doing like a thrombectomy. This is a picture from a thrombectomy you did. There's a bunch of clot that I spread out on one of our lap pads. So contraindication depends on your type of therapy. Some of these patients, like the way that we do pulmonary thrombectomy with the Inari flow retriever, you don't actually have to use any heparin for your procedure. You don't have to use any TPA. So they can have patients like, oh, we can't do these procedures. We can't do ecos because they can't get TPA, they can't get heparin, they can't have a drip. And tell them, well, we actually we can take this patient and we can just take the clot out mechanically. They don't need any heparin, they don't need any thrombolytics. So that's kind of not something not always understood or known, but when they find that out, it can be very attractive to some people. So here's a picture of the pulmonary arteries, the pulmonary angiogram. You're going to access usually the right common femoral vein or the left, sometimes the IJ. It's a very large catheter. You're dialing this up to like a 24 French. So for reference, like the large catheters that we use for dialysis, there's kind of the bigger catheter you might see. Those are like 14 French, like 13, 14 French. This is like a 24 French catheter that's going into their IJ or into their femoral vein. So it can bleed after. So you have to use like a suture to kind of close the skin, the subcutaneous tissue like tightly on top of it. You can use lower dose of TPA if you get into the pulmonary arteries and just drip it directly on there. That's another benefit. It decreases your risk of hemorrhage. You can do fragmentation with like a balloon, or there's some rotating wire type things that will just kind of macerate the clot. You can use rheolytic. That's basically a fancy word for using like basically a jet stream of heparin or TPA and then sort of sucking it out. Aspiration thrombectomy involves either a machine like a penumbra that provides constant suction. It kind of bleeds you out though a bit too, or like an Inari, which is like you pull back on a syringe to create a vacuum, and then you have a big 24 French hole in the end, like a fishing rod, and you've pulled in the clot into it. Sometimes it like lollipops, we call it, where it sticks in the end. And you have to take it all the way out of the sheath, and it's like the clot will be sticking on the end. Sometimes it will pop into the sheath. I think that's maybe the coolest procedure that we do. Complications are rare in these studies where they're doing these procedures and they've evaluated them versus other treatments. Right ventricular pulmonary perforation would be possible because you're catheterizing those. Cardiac arrest because of a really bad arrhythmia that you might cause while trying to get from the right atrium into the right ventricle into the pulmonary arteries. Worsen pulmonary hypertension. Whenever you inject contrast and do a pulmonary angiogram, you are temporarily worsening their pulmonary hypertension. So it's something you need to watch. Sometimes you might not want to do your initial angiogram if it's a very large PE, and you are still going to take pressures to know that. So here I just want to kind of we have a few more slides to go over, and I can keep going quick, but I just want to like let you guys ask any questions, ask stuff about IR. I can keep going with this thing, but I don't want to get monotonous or just keep talking if you guys had questions or anything else you wanted to ask about IR or diagnostic radiology, whatever.
I have a question.
Sure.
So is the artery of Adamkiewicz, is that like that variation that you said with the kind of hairpin vasculature that you see, is that like a typical variation that you see, or is that abnormal that it comes off the bronchial artery?
No, so in those cases, not necessarily coming off of the bronchial artery. It's coming off of the bronchial arteries, I guess, are branching after that, and it's coming off of the aorta at a similar level. So let me go over to my pictures of my bronchial arteries. Your bronchial arteries are going to normally look like this. Yeah. It's like, I guess you have some collateralization from some of these to your artery of Adamkiewicz. So here you can see where your catheter is, and you're catheterizing like a right bronchial artery, and then there's some collateralization to this artery of Adamkiewicz, anterior spinal artery. But it gets some tributaries from that bronchial artery, but it probably normally just gets more of its tributaries from like the rest of the aorta. And I think it's lower down in the aorta where it normally comes off. So you just want to see that you're not supplying that from wherever you're going to embolize.
Gotcha.
And as far as the shape of it, that's not a variant of having that hairpin turn. The hairpin turn is what you look for to suggest that you're opacifying the anterior radicular medullary artery or the artery of Adamkiewicz as a safety thing. But yeah, I think whenever we do these are pretty high up. Like look how high up on the thorax, or these are the heads of the clavicles. So this is kind of like a T5, T6 area, but it talks about it coming off much lower when I've read about the actual artery. So not super clear to me, but whenever you see that, that's when you're worried about anterior spinal artery. And in this case, like you can see it looks like it's collateralizing from up here. So you wouldn't want to embolize from like back here and send something up there. You could go distal out to there. If you go on this right side, and you would just test and inject contrast. And if you get distal to it with a microcatheter after you've parked your mother catheter where you want to be, and you inject contrast and you don't see it filling, then you know you're probably safe. You could do that provocative test, like I said, but usually you're not going to. And then some people will kind of just want to avoid the whole thing altogether because they see that bleeding. But if the patient has life-threatening hemoptysis, they're actively dying, sometimes you have to do what you have to do.
Do you think, because I think you kind of talked about how comparing the PVA to like another embolic, do you feel like with the PVA you get like less like retrograde flow into there or something compared to other embolics?
Oh, no, I mean, I don't know why. Like, it's just classically you use PVA. You need to use like particles for this procedure. You don't want to use coils, for example. If you use coils, these patients, they come back and they have bleeds like multiple times. A lot of the times they bleed and they'll bleed again. You need to be able to get back into these arteries where you went to embolize again. So those particles go very distally. They treat your problem, but they don't jail you off from doing future treatments. If you put a central coil in there, you could embolize this whole thing and take it out, but it will, parasitize and collateralize from somewhere else and then bleed again. You'll have no way to get back into it. Whereas if you inject particles, you get as selective as you can to where you see bleeding. You don't, most of the time actually when you do this, you don't see bleeding, and you are doing this empirically. You're embolizing some of these bronchial arteries in the area where you saw the bleeding before, like on a CT, on a CTA. But you don't have to see a blush or see any bleeding on this procedure to do it, but it'll still take care of the problem. And you can do that multiple times, and you often will, but if you use coils, then you can't. So you could use like Invospheres, which are those manufactured particles, or use like PVA cut into smaller pieces.
So your typical kind of patient for this is like a cystic fibrosis patient that kind of comes in, and even if you don't necessarily, like you're treating empirically based on kind of bleeds that they've had before and where you've shot particles before.
So when you treat them, this is when they have massive hemoptysis as defined by those criteria, and they will almost always have imaging like right before. If they don't have imaging right before, you might go into these arteries, and like you said, you could treat somewhere that you've treated before or see the bleeding on there. But usually you'll want imaging first before you do this, but they might require multiple repeat imaging. It's not like it's never really done electively, because the indication is for massive hemoptysis. So we don't, as of that I've seen, they're not like patients that have a little bit of hemoptysis here and then they have cystic fibrosis and we're just taking out bronchial arteries. It's usually in the setting of massive hemoptysis. We try and find a side that's bleeding from. When you do the angio, you don't necessarily see it, and then in that case, you're still doing it empirically, even though you saw it with imaging before, but you're going to the spot where the bleeding was on your CTA. Gotcha. Kind of like in GI bleeding, if you have a like a gastric bleed, sometimes you take out the left gastric artery. Sometimes you have a duodenal bleed, you take out like the GDA. So you embolize those empirically because the upper GI has such good collateralization that you're not going to get anything ischemic or infarct after your embolization, and taking out those arteries has good success even if you don't see the bleed. Sometimes you'll do, usually you start with endoscopy for an upper GI bleed. They can tag things or tell you where they were, and then you can try and see where that is and see some extravasation of contrast or a blush in that region to have a target. But if you don't, you can still embolize those empirically to stop bleeding. Bronchial artery embolization is sort of the same, but a little different in that you usually don't see any bleeding, but you still do your embolization.
Hey, Tony, can you speak a little bit to, you kind of mentioned it earlier as far as like bedside operations. Can you speak a little bit more about like any future direction with ultrasound that IR is trying to implement as far as techniques or procedures, and how that plays into like certain training that you guys are trying to implement as well for residents? Yeah,
sure. So at MUSC, we've started doing a lot more stuff under ultrasound that we used to do with CT. A lot of this is like biopsies. Anything you start doing with ultrasound, you open up to potentially doing like coming to the patient instead of having the patient come to you. Like for example, all the biopsies that we do a lot of biopsies are mostly in outpatients for stuff, but we end up doing a lot of biopsies like kidney biopsies on inpatients. So those can be done. They were done in the bed when the patient comes in unit with ultrasound. And we're actually going to get one of the rooms to be dedicated. It's like an ultrasound small procedures room. It's still nice to bring the patient to you a lot of the time to manage them. But we can do those procedures, for example, at the bedside. But other stuff like these percutaneous fluid things, we could potentially have like an IR like attending or mid-level provider that's kind of like on bedside procedures days and just goes around and does these procedures that can be done at the bedside. A lot of these things have other providers that will do them, like lines, for example, central venous catheters, but like percutaneous fluid collection stuff like abscesses, aspirating things, those are really done a lot of the time by IR. And sometimes we do those at the bedside. I've done those many times at the bedside myself when I'm on IR, and I've done them at the bedside when I'm on the STICU as like sort of a STICU/IR resident. What else could be done? Like that's one thing. Another thing that could be done in the future is like these gastrostomy tubes. When they do them at the bedside, they use endoscopy. They do probably heard of like a peg trach combo. These are the patients that are going to be sick for a long time. You trach them so they can get off the ventilator sooner. It makes it easier to like do trach collar trials to extubate them, and then they get peg tubes because they have an NG tube or OG tube and they're feeding through that, and they want to be able to feed them, and they know they're going to need long-term enteral access for feeding. So we do those gastrostomy tubes in IR, but you could do them bedside with ultrasound. It's called an ultrasound assisted gastrostomy tube. Actually, I'm not actually seen those, only read about it, but that's like another thing you could do in the future. Central venous catheters. It's always nice to have. I think it's safer and faster to do those with fluoro, but it's not really reasonable to do all your central venous lines in the IR setting. It's too much. We end up doing a lot of them through the hospital anyways, but we do really need other teams to do central venous catheters. Central venous catheters too. Other things like PICCs, midlines. There's a vein team that does PICCs and midlines for the hospital. We end up doing the ones that are difficult for some reason. They come to us, we still end up doing a couple a day. The nephrostomy tube, I can't really see that moving towards being more bedside. Other things like in the ICU, I replaced a pulmonary abscess drain. I aspirated some stuff in the peritoneum for culture. Somebody else has like a fluid collection overlying their orthopedic surgery site that either is a hematoma or an abscess that I'll probably aspirate tomorrow. What else? If you have those like beds that you can floor through or use a C-arm, you can do some adjustments of like Dobhoff tubes and GJ tubes that flip and get their tips to be further down. Some stuff that the patients typically need to come to the unit to the IR unit can be done in the unit, like in the STICU or in the MSICU. Other things really can't be done at all at the bedside, like this. Anything that really requires good angio needs to be done in the angio room. That's going to be like your trauma stuff, your trauma embolizations, all the PE work, your arterial and venous thrombolysis, for example. IVC filter placements can be done with like these angel caths that are like IVC filters / catheters. But in general, it's better to place it IVC filter in IR. You're going to know exactly where it is. You can do contrast and do all the best technique to have a well-placed IVC filter. What else can I? There are some IRs that actually do like tracheostomies. I don't know if they do those in units or not. The gastrostomy tube, like I said, when you do, there's 3 ways to place a gastrostomy tube. You can open up a stomach and surgically place a gastrostomy tube into the stomach and then sew it shut. There's 2 types of procedures, like called a STAM or a Witzel, 2 types of surgeries. There's a PEG tube, which means percutaneous endoscopic, which is you're going to put a scope down the mouth and then you transilluminate the stomach, so you know there's nothing above it, like colon or liver, and then you poke basically a needle into where it's lighting up, and then you look from the inside and you see your needle, and then you grab a wire with your scope from above and you pull it through and through, and then over that wire you send down your tube from the inside to the outside, and it has a retention kind of bumper on the inside. That's how you do it with a scope. So you pull from the inside, so you're not needing to push anything in. In IR, we fill up the stomach with gas, and then we puncture into that gas. We pull up the stomach with Pexi tubes. So we put like tacks on the outside that kind of fix the stomach anterior wall to the anterior abdominal wall, and then we poke through with a needle, put a wire down, and then slide a tube over a wire. Since you're pushing, you have to Pexi or fix your stomach to the wall, because otherwise you will push, but your stomach will come back from the anterior abdominal wall, and you'll create that space between the two. So it needs to be Pexied up to the wall of the stomach. That's the, I guess, downside, but it's just kind of the way that we do those tubes. The good thing is that if you can't pass a scope from above, you can only get like an NG tube in, for example. You can still do it with insufflating the stomach. We can also do them with CT guidance without having to insufflate the stomach at all, and then do the rest of the procedure in fluoro. So we can do G tubes on almost everybody, and they can only be done in select patients with their technologies. But there are multiple services that do G tubes, for example. So I think, and then cholecystostomy tube, that's another one. It's basically, that's like an abscess drainage, but it's in the gallbladder. so to speak. When it comes out, sometimes it's bile. A lot of times it's just like it's basically become an abscess. So it's very similar to your aspiration drainage stuff that you would do at the bedside. And bedside versus IR, like I think if you can get the patient to IR, a lot of times it's better and safer to do. When they're in ICUs, sometimes you can kind of come around and do these procedures for them at the bedside. But I think that's it. Like the major future direction would be like having somebody that's on the schedule that's meant to just kind of go and do some of these consults that we get instead of bringing them there. Is just going to the patients and doing them with all this stuff. And I think that does increase your safety of your procedure if we can find out ways to do them with image guidance. But you need to be able to do them to the same quality that you can in IR to kind of set that as being a standard. Sometimes not everything can be done with image guidance in the way that IR does that, and that doesn't mean that it's bad to do them in other ways. And IR can, when you do a bunch of stuff image guided, and when you do it without image guidance, you kind of see what you're missing more so. So when you place central lines first without IR and then do it with IR, and you see you're passing your wire down, and 95% of the time your wire goes in the right place, and then the other couple percent of the time it goes over into the left side or goes in the left innominate from your right IJ, or it just curls up into the IJ. So the wire will go the right way, and you know you're intravascular, but you don't actually know where your wire tip is. You see that catheter placed, and then they come and they get an X-ray, and it's either in the azagus, it's going across in the left innominate vein, or it's somewhere else where it's inadvertently placed. So you can avoid that always by doing it fluoroscopically guided, but you can't bring every patient that ever needs a central line into IR. So you have to kind of think practical about it too. Does that answer your question?
Yeah, no, that was great. It's always interesting to see like what the direction is, especially if you guys are trying to be more versatile on like you said, like bedside stuff, and then kind of understand like where's the cutoff and the limit of like what procedures are safe and what procedures could be ultrasound guided versus like which ones will never be. So yeah, thanks.
Yeah, I mean, like chest tubes is another good example. Like I guess I asked the surgeons when I was on this rotation this month about like hemothorax. Traditionally, the teaching was like you need a really big tube because it clots off, and if you don't get like one of those larger than 20 French, they have like 20 to 40 French tubes. We place like 6 to 14 French tubes that are much smaller. The blood, you want a big tube. Like gas, like a pneumothorax, you use a very small tube. But they started finding out that you can use small tubes for almost everything, so they place a lot of these small tubes. And they use like landmarks. When we do them, if it's gas, we'll do them in fluoroscopy or in CT to place them so we can see our wire and everything going into the gas. If it's fluid, we'll use ultrasound for like if you're doing a thoracentesis where you're placing into an empyema, for example. So that's something that you could do it at the bedside the same way with the same catheters, or use our catheters but use image guidance to kind of see exactly where you are. And I think it increases your margin of safety like a little bit to use the image guidance, but that doesn't mean it's always necessary. But I think it's good. I think the more and more providers are using more and more image guidance for all the things that they're doing. And I think when you can, most times it shows that it requires fewer attempts and you end up in the right place more of the time when you're using image guidance. So what else? So can you still see my slides? So
yeah, we can see.
Then thrombolysis, that's going to be the reason that some of these patients are in the ICU is actually like they come for thrombolysis because they have an acute thrombosis of the veins or arteries. They end up in the ICU because they have these indwelling catheters. A lot of times we do thrombectomy on like these venous patients now, so they don't need to go to the ICU, but we leave these indwelling like McNamara catheters that you drip TPA and heparin through. And when someone is on there, they require such frequent monitoring that it requires being in an ICU. So for a nurse to check on them that frequently and to document that many neurovascular checks, for example. So they end up in the ICU. Sometimes they'll be an ICU patient, but it's not usually like an ICU patient that develops like an emboli or something that comes to IR, and then that's why they're in the ICU. Usually it's the procedure that we do because they came into the ER or vascular surgery does, and then they're either in step down or in ICU getting this thrombolysis. So this is when you have like acute systemic pulmonary artery or systemic or portal venous. So basically any of your vascular beds have an acute thrombosis, and you have a higher chance in fresher clot. TPA works better on the freshest clot, so less than 2 weeks ideally. And then you can also facilitate your clot removal by macerating that clot or using mechanical methods and devices, or you can put a catheter right against a fresh clot, and instead of giving a patient systemic TPA to dissolve it in heparin, you still give them heparin, but you would drip your thrombolytic right on your clot. So you try and get your wire to cross through the clot, and then place this catheter, like it has multiple side holes, through the clot too. So it drips all around, embeds the clot in TPA, and resolves it. So you have to be able to have time. If you want to do like a catheter-directed thrombolysis, it can't be in a foot that's going to be like completely ischemic and dead in like 2 hours. If it's progressing that way, that patient needs to go to surgery to get revascularized immediately. You don't have time to do catheter-directed thrombolysis. Sometimes you'll take this patient into vascular first and try and clean out that artery, and then you leave the catheter-directed lytic catheter. You leave the lytic catheter in there after to kind of lyse the rest of what was left over, but you've like reperfused the limb in the meantime. Because you're doing the same thing like I talked about in that PE case, you have a risk of intracranial hemorrhage and other hemorrhages, often at the access sites that you have. Intracranial too, that's the major scary thing that can happen. And then if you've had like recent things that can bleed, like a trauma or a surgery, currently pregnant, and like I said, you have limited time for limb salvage. So if you need to salvage a limb right away, a lot of these patients are going to be better served by surgery or with a hybrid approach with surgery / endovascular. But I mean, they do like vascular surgery with hybrid procedures. We'll still do like this catheter-directed arterial and venous thrombolysis as well. So it's not like IR, or they either go to IR or vascular surgery, so you get one type of treatment or the other. It's, you know, both providers are, we don't provide surgical therapy, but the stuff of endovascular that we do is very similar. A lot of it crosses over. So this, you need to access upstream of the lesion. If you're in a vein, that means you're going to be more peripheral. I like to, venous convention is like get closer to the heart, that's distal. So more proximal in a vein is going to be farther away, like in a foot would be like a very proximal vein, and then distal would be more central, like in the IVC. It's going to be proximal or upstream of the lesion, so that where you're dripping your lytic is going to drip down into your lesion to lyse that clot. You need to access upstream of the lesion. So if you have like a DVT in the leg, you might get like popliteal vein access, so that you can drip that lytic into your femoral vein or iliac vein clot, for example. You're going to do this thing. This can be for a long time. It can be like multiple days. They do this. But you do them in maybe like 8-hour, 12-hour periods. Like you leave these lytic catheters, you bring them back in, do more angio in the morning, see if you need to do more clean out, see if you need to do more drip. Like I was saying, you need to go to the ICU because they need to get fibrinogen, INR, PTT, all these things monitored frequently. Major bleeding up to 6.6%. Another thing about revascularization you always got to think about with legs is a lot of these patients end up with like tight compartments. They can get compartment syndrome, and they might need fasciotomies too. So you need surgery involved for a lot of this. Inferior vena cava filter replacement. These are some variations of inferior vena cavas and where you might want to leave a filter in different instances. So it's usually infrarenal. You put the hook right at the inflow of the renal veins. The idea is that will, if you were to get thrombosis below your filter, you're not going to get renal vein thrombosis and potentially end up on dialysis. But at the same time, you have inflow from these renal veins, so it can kind of bathe the stuff that's in the filter and let the clot naturally break down that it catches. And these are different examples of like duplicated IVCs or anomalous IVCs and where you might want to place filters. Like you could place here, you have this vein coming from like your left leg, left iliac, and it's draining to this left renal vein. So in this case, you could either do A, you could put a filter right in there and right in there, so that you capture clots from either way and you still stay below the renal veins in case you get clot and thrombosis, or B, you could just go above both of them and have basically a suprarenal IVC filter. So these are kind of controversial. There's some indications that are not controversial at all with IVC filter placement, like if you have a DVT or PE in a patient that you cannot anticoagulate with a strict contraindication to anticoagulation, it's a good idea to place a filter. If they're on anticoagulation and anticoagulation fails, you can't switch to one that will work, or so they're on anticoagulation and they're therapeutic, but they still develop a pulmonary embolism, for example, that'd be a time to do one. And then selectively, not as firm as these other indications, but still pretty strong, is in patients that have a submassive massive PE, and they're getting advanced therapies, like you're doing some, you could place it intraprocedurally before you lyse clot in the legs to not send some to the pulmonary arteries and take it out immediately after, for example. Another one would be like somebody that has a very large PE, they have DVT, they're getting treated, but they're just teetering on the verge of any more DVT, the embolizes to the lungs, they might not be able to handle, for example. That might be a patient that you put an IVC filter in because they have poor cardiac reserve from that PE. That's more of a controversial thing, though. The real indication that's like nailed in is this DVT PE in a patient that can't get a filter. And ideally, somebody with filter, you want them to have filter and anticoagulation if you can. That's going to have a better outcome. With just a filter and on your own, it doesn't necessarily improve mortality, and you get a lot of thrombosis below the filter, so you can thrombose your IVC, iliac, and femoral veins in your legs. Contraindication, if you have total thrombosis of the cava, there's nowhere to put your filter. If you can't access the cava, And if it's greater than 2.8 centimeters, it's considered a mega cava. You need like a bird's nest filter, which just looks like a mess of wires. I don't know if you look that up. I don't think I have a picture. Actually, I do, right here. So these are the struts of this filter, and then it has all this wiring. So it kind of fills up the IVC. You can use it in a larger than 2.8 centimeter one. You can come from above, common femoral vein, below a common femoral vein, or above from the IJ. You do a venogram, especially if you don't have a CT, to delineate where your inflow for renal veins is for placement. And you should look at a CT, know which lumbar level you want to have this filter at, know where your renal vein inflow is, and you don't need to use as much contrast. After you place it, you'll do like usually one more venogram. Some people don't, some people do. Cable thrombosis can happen from filter and fracture. Penetrating the IVC, like if you look at CTs on these patients that have IVC filters after a few months or a year, almost all of them have some of the tines that are penetrating the wall of the IVC. It causes no problem. It's basically an expected finding. Sometimes it gets reported in the CT, sometimes it doesn't. It's probably nothing to it. You take them out, it's not really contraindication. Sometimes if you see it penetrating to something else, then you think about it more, like it might penetrate into the aorta. In some of those cases, we'll get like arterial access as well and be ready with a balloon in the aorta to occlude it if you take it out and they're bleeding. Usually take it out and nothing happens though, even if it's penetrating like a lumbar vertebral body into the duodenum or some other bit of the small bowel or colon or anything. Usually take it out, causes no problems. You might want to use antibiotics in those instances. Sometimes you watch a little more carefully, but usually causes no issues. Here's a couple of adjunctive ways to remove filters that don't come out with the typical way of just using like a loop snare. This is a forceps. You can kind of dissect some of this ingrowth around the filter tip. This is a laser sheath. I think it's from electrophysiology, I think. And basically you get around the filter when it's stuck to the wall, you turn on the laser and it basically burns down it to capture it into the sheath. They've shown that with these techniques, you can basically get all like 100% of filters. I think it was a big Northwestern study that they showed that. So GI bleeding, upper, I talked to this about this a minute ago, like endoscopic therapy first is the answer for upper GI bleeding. If you're ever, a radiologist on call sometime and they're gonna call you and you're going to ask like, where is the bleeding coming from? Have they localized it? Do they have imaging yet? Have they had endoscopy yet? So if you have refractory arterial bleeding that you can't treat with an endoscopy, then you can embolize. Like I said, you can do empiric. You can perform with an endoscopically localized lesion, so you see where the bleeding is. Even though you do an angio, you don't see extravasation or even blush. You can still treat the culprit vessel and stop the bleeding without actually seeing it in real time. If it's variceal bleeding, then you're not going to want to do arteriography. You're going to want to treat that by treating portal hypertension with the tips or actually treating the varices directly themselves with the BRTO. Lower GI, the sensitivity of these studies, CTA is in the middle, angio is a little less than, then tagged right blood cell has the highest sensitivity, but doesn't show you as specifically where the bleeding is coming from. And you want to get one of those studies first before going after it and embolizing a lower GI bleed. The collateralization isn't as great down there. So you want to be selective as you can, but you have to be cautious with embolizing those because the blood supply isn't as collateralized as an upper GI, so you can get bowel ischemia after. So these always require fluoroscopy. This isn't something that can ever be done like in the suite or in the ICU or at the bedside. You're going to get common femoral or radial access. You localize the bleed, get as selective as possible, and then embolize. There's a lot of different things you can embolize with. You can use glue. You can use coils. You typically don't want to use, particles in this situation because it would go distal to bowel and infarct that bowel where it's going distal to. Sometimes when you want to use like particles versus coils, depends on if you want like a proximal versus distal embolization. Sometimes you do, sometimes you don't. Different things. In gastrointestinal bleeding, it's going to be more like coils and glue. Access site complications can happen anything where you're getting access, especially like into the arteries. Vasopressin is something that you use. You can actually use a medication as sort of embolic, but basically it clamps down on those vessels to stop the bleeding. And you can basically leave the catheter and then drip vasopressin into it to stop the bleeding. That can cause cardiac complications because of your vasoconstriction that you're getting with the vasopressin. Non-target embolization is where basically after you've embolized and you stop that antegrade flow, you start getting retrograde flow through your catheter. It goes up into your catheter and embolizes something else you didn't mean to. And then bowel ischemia, like I said, upper GI, it's rare. With a lower GI, you need to be, more certain of where you're embolizing because it can be as high as 6%. Do you guys know what a TIPS procedure is? Yeah, in general. So this is for portal hypertension. Portal hypertension can cause bleeding, can cause portal gastropathy, it can cause gastric esophageal varices, causes all these various shunts to go from the portal system to the regular venous systemic circulation. Can cause hemorrhoids, for example. You want to reduce your portal hypertension by reducing that portal systemic gradient. So the gradient between your portal system and your right atrial pressure, you want to be less than 12. In cases of ascites, sometimes people say you wanted like half the gradient of what it was. So you have variceal bleeding or refractory ascites. Ascites are requiring like large volume paracentesis every week or two, for example. Hepatic hydrothorax, that's like ascites but in the chest. It's where usually on the right side, and you just keep getting these large pleural effusions because of your liver failure and your portal hypertension. And then hepatorenal or pulmonary syndromes, that's where because your liver's failing, your kidney's failing, or because your liver's failing, your pulmonary arteries are failing. Budd-Chiari, that's when your hepatic veins thrombose. You can kind of get through those. So contraindications, you can't do these in heart failure. So everyone that gets a TIPS is always going to have an echo first. If your MELD score is greater than 25, the MELD score is actually used for liver transplants, a lot of other stuff with liver now, but is initially designed for TIPS as a mortality score. So it's going to be like the best test for that. And then severe encephalopathy, you're shunting through the liver. So the liver normally detoxes you and takes out that ammonia. But because you're going through the liver, if you have encephalopathy, it's not well controlled, it's going to get worse. So you can shut down tips that you make, or you can make them smaller. So you can do a constrained tips, for example. If someone gets encephalopathy, you can always shut down your tips that you create. If someone's encephalopathy is intolerable after. So say you did this for ascites, but then they got such bad encephalopathy after, you could shut it back down. They're gonna have ascites again and portal hypertension, but they probably won't have as bad of ascites. BRTO, this is where you're going to go straight after the varices, rather than going for the for tips for reducing portal hypertension. In this case, you're going to go through the venous side, and you're going to get into those varices. Like say you have like a splenorenal shunt, so you're going to get into like the left renal vein, go into that splenorenal shunt, and you put maybe glue right into these varices. Use a balloon to occlude it so it doesn't like reflux back into your venous system. If you use a plug, you can use a plug so you can put a sclerosant into this varix. You don't have to wait with the balloon. With the balloon, you have to put it up, wait maybe 4 hours or more, and then put the balloon down after it's completely, the alcohol has dried it up or your sclerosant has kind of destroyed this varix. With a plug occluded, you can put your embolic in there and put your plug up like an Amplatzer plug, and then you're just done. You can get out of there. You don't have to wait because you basically occluded it and put your sclerosant in there. You just leave it in there. And this, because this is going to shut down one of your shunts that's offloading your portal hypertension. This could make your portal hypertension worse. So it's going to treat that one varix and bleeding maybe from this one varices, but you might develop more varices, might develop more complications from portal hypertension, like increased ascites or hydrothorax. Your balloon can rupture that you have up while you have your sclerosant in there, and then you can get like systemic venous sclerosant, which can cause DVT and pulmonary embolism, for example. Body removal. If it's an intravascular foreign body, you can usually get it out endovascularly. Some interesting ones with this will be like someone might get like shot in the abdomen or shot in the pelvis and have a bullet that gets into an artery and then actually embolizes distally, causing a blood flow compromise to the foot. You can take that out endovascularly. A lot of the times it'll be like fragments of a catheter that get lost that we can go in with a snare and take them out. Central venous catheters. This is often done in the ICU without fluoroscopic guidance, but pretty much always done with ultrasound guidance. The things to know about central venous catheters are like the types of them. Non-tunneled are going to be ones that basically patients have them in the hospital and they come out before they leave. So you might get hemodialysis, their non-tunneled catheter. If you want to have a long-term catheter, someone wants to go home with it, you're going to have like a catheter with a Dacron cuff that gets tunneled into the skin. Before you access the vessel, you basically take the back of the catheter, and then you tunnel through it. You have your catheter sticking out the skin, then you put your catheter down your wire, and you basically have a tunneled catheter with a way to access it without having to have a direct connection between your vein and the skin. Ports have longest central line associated blood stream infection. If you use it appropriately, that means not accessing it like all the time. And PICCs are for intermediate term. You can tunnel a PICC and have a cuff and be, I guess, safer than a regular PICC as far as infection. There's basically no contraindications to non-tunnel catheters. These are placed in very sick patients a lot of the time. It's like in the ICU or in the trauma bay. So often they're placed emergently. So even if somebody has, bacteremia, you can still place those catheters. If they have a bleeding diathesis, if they have a coagulopathy, you can still place those kind of catheters. Tunneled, you kind of want to make sure they're more optimized, that they're, INR platelets are more appropriate. They don't have bacteremia. All those are kind of things you need to think about with tunnel catheters, and that's why they're sort of more of a long-term. But no one really ever emergently needs a tunnel catheter. They'll emergently need non-tunnel catheters. IR gets involved for some of these if they were difficult to place at the bedside. Sometimes they're a patient that's not in an ICU, so they'll come to us for their non-tunnel catheter, like an HD line. So we use ultrasound for access, use fluoro guidance to see what you're doing. Here's an example of like a central venous catheter. Here, this is the Dacron cuff right here. This is like a non-tunnel catheter. This is a tunnel catheter. You can have complications with these. I've seen like a mediastinal hematoma from one placed with ultrasound at the bedside, for example. Sometimes you don't even know exactly where you are if you don't use image guidance. And trauma is the last thing that I had in these IR residency ICU rotations. So trauma, there's too much to address kind of everything with trauma, but aorta injuries, pelvis, liver, spleen, kidney are going to get embolized often. Extremities, you don't want to embolize something if it's like a superficial femoral artery that's injured and it's bleeding from there. You might place a stent into there. If it's it depends on basically the nature of the injury. If it's a small bleeding branch or something, you can embolize that and be fine. If it's a vessel that's damaged and the patient is very young, they might do better with a surgical repair. Sometimes a stent graft can be appropriate for that. It really depends. For the other stuff in the abdomen, for example, like pelvis embolization is first. The reason is because pelvis is so hard to access, like surgically, deep down in to treat those injuries. So you basically are going to go for all these, pelvic ring fractures that have associated extravasation and go to IR. IR residency ICU rotations. I'm actually on one of those right now. The reasons to do this is because you kind of enhance your understanding of critical care management and bedside procedures. Definitely helpful for me so far. Resuscitating unstable patients. A lot of times we have unstable patients that come to IR, and being able to manage these patients to some degree, at least to get them safely from ICU to IR and back to the ICU. It's a good thing to be in the ICU and be familiar at least, with all kinds of monitoring, basics of ventilator management. Seeing bedside procedures. Actually, I haven't seen a single pulmonary artery catheter since I've been in the ICU this month. I've seen them before. Done some venous access, done arterial lines. I have done chest tubes in the ICU so far. Haven't intubated anybody, but you see that all the time. They do a lot of bronchs. I'm probably going to get involved in some of those in the next week and a half. And then peg strakes. I did some of those as an intern. I've helped them out with some of those there. I'm probably never going to do trachs in IR, but peg is interesting to see their techniques different than the way that we do it. But there's some crossover the technique. I think it's good to see how they do pegs because we convert those a lot of times from a gastrostomy to a gastrojejunostomy. Or for example, someone's peg tube came out today, which is a fresh peg tube, and they call it IR to do it tomorrow. So in the meantime, we placed a Foley catheter through it. We put the balloon up, we pulled it back, we injected contrast. We got x-rays to confirm that we're actually still intraluminal so that we're not leaking gastric contents into the peritoneum. And then we send them to IR tomorrow. So all the stuff, the interfacing that you're going to do with all these other specialties and being able to manage critically ill patients is a really important thing. And then critical care fellowship. This is a thought. It's something I think is pretty far off, but it's a possibility. There's actually one radiologist I know at University of Pennsylvania that practices actually a critical care surgery attending. It's the only example I know of, but from being in the ICU, I could see that it's potentially a good thing. I think you'd be excellent or maybe the best at like bedside procedures from the stuff that you do in IR. So that'd be very helpful there. You're not going to obviously take them to surgery yourself, but for management of the problems and doing like critical care type procedures, I think it's a really good specialty to do. And if you wanted to do critical care and do IR, I would say don't count it out. You could probably do both. I don't know that there's a lot of established pathways to do that, but do get a lot of exposure to critical care and to interventional radiology. At least through the residency, I've done 3 ICU rotations already. Probably do 4 in the future going forward. So that's what I have to say about critical care, VIR, and what we can help out with critical care. If you guys have any other questions, and this is kind of a long chat. Hey, Emily and Matt, thanks for coming.
Hey, Tony, thanks for that.
Yeah, of course.
Also, your daughter was super cute.
Oh, thank you.
I have a question for you, Tony.
Yeah.
So what are the contraindications of like why you would want to do like a BRTO over just doing a TIPS? Like, is it just like more emergent, like variceal bleedings, or you're like, I got to go in there and like I need to probably try to shut that down sooner than like waiting on the TIPS, or like what drives you to a BRTO versus TIP?
So BRTO was done historically, like in the development, like more in Asia and like Japan than we did it here. And I'm not sure if it has to do with the epidemiology of how their lesions were, like their varices and what they were due to. But the way that it breaks down for us is that it depends on like, does this patient have bad portal hypertension that needs to be treated as a cause for their issue? If we shut this down, this VIRIG, by doing a BRTO or PRTO, do they have like multiple other varices that are going to actually get more flow and be more likely to bleed? To the things that could get better if we treat their portal hypertension, like the ascites or hepatic hydrothorax, in addition to portal gastropathy and varices that have bled, for example. So you have all these problems, and you don't have that, and you have well-controlled hepatic encephalopathy, then TIPS is going to kind of be your answer. If you have an isolated, like large VIRIX that needs treated, and otherwise like not like terrible portal hypertension, there's kind of an algorithm. We actually had a lecture on this that Dr. Uflacher gave pretty recently about like what combination of findings you'd want to do to lead you to one or the other. For example, if a patient has terrible hepatic encephalopathy that's uncontrolled, you don't want to do a TIPS, for example. And a BRTO can potentially create your physiology that you actually go more through the liver, like there's less shunting, more through the liver. So potentially your hepatic encephalopathy could get better with a BRTO, but your your portal hypertension could get worse. So it kind of depends on the individual patient and what you want to do. An example of someone that we treated with a variceal embolization is someone that had something called portal steal. Like after you get a liver transplant, typically like splenic steal is the common thing, where because you have too much of the artery flow from the celiac going to the splenic artery, it steals from the hepatic artery, and the new liver needs the hepatic artery flow, so you embolize the splenic artery and it sends more of the blood flow to the hepatic artery. Usually these patients that have these liver transplants, a lot of times they'll have portal hypertension too. And because they have portal hypertension, you put that new liver in, that new liver has less resistance than the other portal system because it's not cirrhotic. And those shunts shut down right away, so everything goes right through your portal vein. We had an interesting case of portal steal, which actually even the people that were documenting it were, calling it, they were calling it splenic steal because it is called a splenorenal shunt with portal steal. But it was those large shunts that did not shut down after they put in the new liver. They still filled. So we actually went in and embolized the splenorenal shunt to direct more of the portal flow through the portal vasculature because they had portal steal. So when they improved their portal perfusion, they actually got better because we shut that down. So that's an interesting, like, unique case because after a liver transplant, usually those varices, you'll still see all these shunts because they have portal hypertension, and then they'll go away after you deliver within a matter of hours. So it's not common to still have that. But yeah, BRTO TIPS is kind of just depends individual patient, and then kind of like a flirt. But the clearest thing would be like lots of problems with portal hypertension, not bad hepatic encephalopathy. TIPS is the way to go. If you don't have like other problems with portal hypertension and you have a large VIRIX that can be specifically treated with a BRTO might be the way to go because you're not going to cause a new. You can cause a new hepatic encephalopathy to a patient that doesn't already have it, that has liver failure, can have hepatic encephalopathy without having it at baseline after TIPS.
Gotcha.
And then practice patterns the other, like the lab. We probably like are more TIPS forward here than places that might do BRTO first. But I tend to think that if you have multiple problems from portal hypertension, the TIPS is going to be your way to go, rather than just the BRTO might just put a Band-Aid on it in the meantime, and then you're just taking out one of those shunts, and another one is going to get worse.
Gotcha. Michael, by the way, if you want to ask him questions about just IR as a field, because I know you're kind of our sole preclinical student, I think Tony's open to those as well.
Yeah, of course. Anything you guys got?
Yeah, I was actually just thinking about what you were saying earlier about the bronchial artery embolization, and I heard you mention PVA. So in general, is that like when you're trying to target like the distal capillary beds of like an artery you're interested in embolizing versus like coils which just block the artery itself?
Yeah. So the size of your embolic material is going to determine how distal you get. So if you want to start getting very distal because you're embolizing like a bleeding renal tumor, or you like want to completely embolize a kidney, for example, so you want to get lots of particles distal, or you want to do a distal and proximal embolization, then you start with like small particles and get bigger and bigger as you go. So your small particles are going to basically clog up everything, and your bigger particles are going to clog up more proximally, and then your coils are going to take out like the large vessels. When you use coils, you're basically putting something in there. You still get blood flow through there, but they're very thrombogenic, and they basically thrombose entire vascular beds, and there's no way to get through it again. But you can like collateralize around the coil, or if they have blood supply beyond the coil, then they can still get perfusion. So like, for example, in a spleen, we do these proximal splenic artery embolizations, usually with coils. So if you place particles, it's just going to flow distal. You can't control it. You're going to get a distal embolization. If you use the coils, you can do a proximal splenic embolization. They still have perfusion to their spleen via other things like the short gastric arteries and other collaterals. But you take off the pressure head, so you stop the bleeding without completely killing the spleen. So they don't need to get, their splenic vaccinations. They don't need such extensive like antibiotic prophylaxis for splenic abscess, for example. So if you want to get right into the vascular bed, like with a uterine fibroid embolization, for example, that'd be another reason to use particles instead of coils. It just kind of depends if you want to get proximal. Then glue can be like both, depending on your viscosity of your glue mixture. If you make it more viscous, you can be more proximal. You can use things like onyx that solidify after a certain time. It can be more or less viscous. You have more time to like manipulate onyx than you have with glue. With glue, you basically have to do your maneuver quickly because the glue can start to polymerize, and then you can actually get a catheter like stuck inside a patient. We actually have to cut the catheter off and leave it because it's glued inside of them. So it kind of depends on your indication. So like a trauma embolization for like pelvic artery, like internal iliac bleeding, you're going to usually find an internal iliac artery that's bleeding. Some people will empirically embolize both with gel foam. Gel foam is interesting because it can be like more of a proximal or a distal embolic agent. If you make like a slurry where you sort of mix it between like a three-way cock and a syringe, then you can embolize distally. But you can also embolize more proximally by making like a gel foam torpedo. And gel foam actually absorbs after a few weeks, so you could potentially recanalize the internal iliac arteries after your like bleeding injury has resolved and not potentially cause as much ischemia. It's not really super clear in that case, but you can even embolize both internal iliac arteries and not have problems. You could occasionally have, ischemia in the pelvis or buttocks from that type of procedure, but it kind of depends what you want to embolize. If you ever need to get back in that vascular bed, coils is going to be kind of dangerous to do so. Coils is quicker than particles. Particles you need to do for a long time and kind of watch them inject and go as distally as you want them to. When you're doing embolization of tumors, for example, you need to use particles like with a transarterial chemoembolization of a liver tumor, because you need to really get into, like you said, those very small arteries to occlude them with those particles. Otherwise, if you get more proximal, those things parasitize tons of blood supply, so you're never able to get all the blood supply off by just using a coil to embolize. You can use coils to like take out entire like vascular perfusion to an organ if you do it very proximal, though, like with a liver that doesn't have a lot of other collateralization besides, it has the portal vein that supplies it, but you could take out like a whole hepatic artery, or if you needed to, you could take out like a whole celiac or an SMA. I've seen an SMA being taken out by coils proximally in a case of a pancreatic tumor that had eroded into the SMA, causing like a massive bleed. Surgeon was there, and we're like, okay, we can try to do this. They will probably get, bowel ischemia and lactic acidosis and die, but it's the only way to stop the bleeding. We did it. The patient ended up dying, but they lived for a few more days, able to say goodbye to their family, at least instead of dying from that massive GI bleed. But coils are a quick and proximal way to embolize. Particles are going to give you more of a distal embolization. When you don't want to actually kill the tissue but stop bleeding, coils are a good idea. If you actually want to kill the thing that you're embolizing, then particles could be better. So like particles you wouldn't want to use for like a GI embolization. Particles can also go non-target more easily than coils. Coils, you place them where you place them, and then they're done. You can have coils swim downstream a little bit, but usually you size them a little above the size of the vessel, and then you can tightly pack them in there. And then you might put some gel foam into a coil after you're done. But with like a upper GI bleeding, you don't want to put coils where you don't know where the blood supply goes after some things. When you embolize something, sometimes you get backflow. So you might embolize, put coils in, and then when you put particles in, you get maybe you're embolizing your GDA from one side, then you're going to get flow from the other side. It's going to send your coils back out the other way, and you're going to have some non-target embolization. So that's why you kind of need to be, every procedure has some embolics that are indicated and some embolics that are contraindicated, and it matters, you know, what your goal of your procedure is, how much you want to embolize. You want to completely embolize? Do you need to get very close to the lesion distal, or do you want to do it more proximal?
Thank you, and thank you for the presentation today.
Yeah, of course.
Tony, I have a question for you. So, fourth year we have to do an ICU rotation. I don't know how many of the different ICUs you've been on, but do you think there's a particular one that's more valuable going into IR to like rotate on? I
mean, I have the ICU that I've been in here like for 3 months, like this month, and then 2 months as an intern is the surgical ICU. It's good, and I've been exposed to other ICUs just as a consultant. I would say probably either like the MS ICU or the STICU. MS ICU is good. It's run by anesthesiologists and pulmonologists, but you still have surgical patients that are in there, and a lot of surgeries that happen. Or surgical ICU is just surgeons. The surgeons are the intensivists too, so you don't get that like medical intensivist perspective. But either one is kind of worth it to see. The MICU, you're going to get bogged in a lot of like very, very sick, complex medical patients that are, a lot of them, you know, there's not a lot of hope, and it's complex. You're running them for a long time. You're talking about a lot of complex problems, and it's like maybe this one person will need an IR procedure someday and make it very interesting to you as an IR. And for the most part, you're going to be like just dealing with patients with like lots and lots of comorbidities and problems. In the STICU, patients might come in and they're like have a splenic trauma but otherwise healthy, or you know have a polytrauma but otherwise not have a lot of medical problems going on. And as an IR, your job isn't really managing like multiple complex medical problems. It might be managing a complex medical problem or a few medical problems that are related to something you can do a procedure on, but not so much managing all of the things in medicines and those kind of things. So that's why STICU is good. MSICU is good too. Both of those are good exposure. MSICU, you get exposure to more like the vascular patients and the GI cancer people that are having surgeries over there, and the biliary stuff. Biliary drains gonna be way more frequent over there. You get cool high-end IR there, and then the STICU is gonna be a lot more of the like traumas, like G tubes, those kind of things. So either one is good. I think at an MUSC in your PGY1, you do 1 or 2 STICU rotations plus you do trauma. In your PGY3, you probably be in the MSICU as a radiology resident if you're in the IR integrated program in the future, and then your PGY5 back to the STICU again.
Okay. Michael, did you want to ask Tony about anything about like applying to like IR or anything like that?
Yeah, you know, I just maybe wanted to hear his thoughts, just since they've developed, like recently they've developed the integrated program for residency. Do you think that changes anything? I know it's like obviously like much more competitive now, but there's also like different pathways, like Nathan's explained. Well, what are your thoughts just about you know, I guess giving yourself the best chance to match?
Yeah, so I think IR is like a really small field, and I don't know, like there's limitations with away rotations with COVID, and there has been the past couple years for that. When I actually did 3 away rotations. If you knew your own local department, you could have a good chance of like staying in a place because it's so small. These like rank list and number of programs was small. When I applied the first year, I was the first official year. Before that, they opened up some programs early, and they said like if you applied to DR, you can add IR to the list. It was like 10 or 12 programs initially. And the year I applied, I think it was like 61. And it's really competitive at first, and so the things that are going to be used to like screen people are going to be like their step scores, for example, clinical grades and all that stuff. But I think like the most like important thing that like gives you the greatest chance of success is, say if you just interviewed at places and you don't get a chance to meet people and you have a really good application, I think you still have a really good chance of matching. But the best thing you can do is like make really good relationships with the IR people, like residents and attendings at your own institution, and if you do aways at their institution too. And that's how people start talking about you, and you become like a known entity to that institution, and also talk to the other institution about you, and you kind of get a good reputation in IR. So you'll go rotate maybe like Vanderbilt, you get a lot of recommendation from them, they all really like you, they write it back to our program, they like you too, and you kind of get like that halo of like being really known, like a known entity to the IR program. And that's good because when we have applicants for IR, it's 2 spots. And MUSC, we interview like 30 people. So, and we talk about them in the whole DR committee meeting and IR committee meeting. There's not that many people. So if somebody comes in, we're like, we don't really know who this guy is, like, then that makes you kind of like an outlier because you're not really familiar to the IR department. It's a small sort of community. So that doesn't mean you're going to be like put to the bottom of the list, but it's just like if there's a lot of people that we do know pretty well from doing projects with IR, being around, doing rotations. So if you're interested in it, I guess my best suggestion is just kind of being involved in IR stuff, get to know the attending. Is like they're all interested in, college students, medicine, anybody that's interested in IR wants to come and talk to like Dr. Johnson, Newflocker, Ramirez, Yamada, anybody, and just say like, hey, I'm interested in IR, I'm this and this year, and then they'll try and recruit you, and you kind of be a known person. So I just would not get to your R4 year having not done a lot of interacting with your local interventional radiology department, because that'll have your best chance of matching there, but also really increase your chances for other places, because they're going to know VIRs at MUSC, they're going to write you letters for these other places too, and that's going to be, I think, more of an impact than some things like medicine that have tons and tons of applicants, tons of residents. Not everyone doesn't know everyone because it's so big. In IR, there's going to be a lot of like, personal stuff that's involved in it, as opposed to just like the score stuff and the application numbers and that. So if you like it, hang around and get to know everybody. Make sure the residents know you. The residents are going to be involved in your and like your matching success and scoring too, and they're going to, some of them will be on those committees where people are getting ranked. The program, you have to know the program director, diagnostic radiology and IR. You got to show interest in both. Even if you don't like diagnostic radiology that much, and you want to end up being a proceduralist, and diagnostic radiology is sort of your path to there versus internal medicine for cardiology versus general surgery for vascular surgery. Like you have to work with the same people. You need to be a good diagnostic radiologist, be a good interventional radiologist. So you need to show that you're interested in both. I guess if for the IR integrated programs, you also want to show that you're dedicated to IR and not going to leave the program because you're not sure about doing IR. So if that's the case, that might be a better thing to do, like diagnostic radiology with ESIR to get into IR, because it being so small with 2 residency spots, you don't really want to match people that are definitely going to do IR, so they're not peeling away into your diagnostic radiology program. You need to fill those spots with outside people or match more people through the independent program. So just get to know the people is the strongest recommendation I have for you, aside from everything else. Just all the other stuff is going to be the same for everybody. Do a good job, get good grades, get good steps, do the best you can, but you can only do so much for those, and then it's kind of done out of your control. You can always get to know the program better, get around, learn more about IR. They want to see people involved in SIR if you can, try and publish something in IR, have an IR application that says this guy likes IR, he did IR things while he was in med school, he's serious about it. If the application reads okay, this guy seems like he has an ortho project and something with pulmonology, there's an IR rotation here, we weren't really sure that much if he wanted to do IR when he rotated through, and no one knows in the department, then it'd be more of a questionable applicant, even if they have good scores. It's not as sure that person is really interested in IR. So that's the best advice I can give, I think. And you can do all that stuff despite whatever happens to you in med school with clerkship